Hi guys, this is Doreen Hughes and today we're going to do a short presentation on acute skin failure. The consequences of acute skin failure. Altered hemodynamics. This is peripheral vasodilation, increased blood volume, and high output cardiac failure. Next we have altered thermoregulation. This is your hypothermia and your hyperthermia. Metabolic abnormalities, your hyperglycemia, your glucosuria with associated pancreatitis, decreased insulin resistance, stress, and infection. Your fluid and electrolyte imbalance. Percutaneous water loss far exceeds the usual 400 mLs per day. And your nutrient loss. Diffuse skin, scaling, shedding, oozing, leads to protein, iron, and B12 losses. A pressure ulcer versus acute skin failure. Your pressure ulcer is your localized injury to the skin, usually over a bony prominence, and the pressure just sits on the skin, causing it to start to break down. Your acute skin failure condition is where the skin and underlying tissue dies due to hyperperfusion. It occurs with the severe organ failure or dysfunction. A pressure ulcer and acute skin failure are two distinct and different yet related conditions. They can occur simultaneously as failing skin can increase susceptibility to pressure. So, what is acute skin failure? Acute skin failure actually has a code, L98.8. This is when your patient comes in, usually on a vent for more than 72 hours. Organs are starting to fail. They have acute renal failure, acute liver failure. Their toes are starting to turn purple or black. Their legs are becoming mottled. Their abdomen is red or mottled. And the skin is also an organ and it is starting to fail also. So, the National Pressure Ulcer Advisory Panel defined unavoidable pressure ulcer as an ulcer that forms because of an individual's clinical condition and risk factors, despite the proper application of standard prevention measures. A Kennedy terminal ulcer is defined as an unavoidable skin breakdown or skin failure associated with the dying process. But what they don't tell you is the Kennedy terminal ulcer, if it is not present on admission, is considered a hack or a harm, even though your patient may be dying and there's nothing you can do to prevent the skin from also failing. If Kennedy terminal ulcer is documented, it is a hack or harm if it wasn't present on admission. Acute skin failure, not present on admission, does not create a hack or harm. So we need to see if we can get our physicians to document acute skin failure if the indicators are there. So when do you consider acute skin failure? Well, a current pressure ulcer prevention and intervention must be in effect. This means that we need to be doing our turning every 2 hours, keeping the skin clean and dry. We have them on the LEAF program. We may have them on an air bed or water bed. We're turning them to get the pressure off, and they're still having skin breakdown. We need to make sure we're documenting that the toes are blue or black, that they have hypoperfusion. They may not have any pedal pulses. Their skin is becoming mottled. Their abdomen is becoming mottled and red. So acute skin failure can't be accurately distinguished from a pressure ulcer if there are no current preventions in place. So the current prevention has to be there and working and documented, and the skin continues to fail, then we can document acute skin failure. Pressure ulcers can be distinguishable from acute skin failure in that they occur because of unrelieved pressure resulting in ischemia and necrosis. Again, acute skin failure occurs because of hypoperfusion. So we're going to differentiate between pressure ulcers and acute skin failure. Acute skin failure is a possibly Possibility of critically ill patients with altered tissue perfusion, hemodynamic instability, and organ failure. Predictors for acute skin failure: PAD, mechanical ventilation greater than 72 hours, respiratory, liver, or renal failure, severe sepsis and septic shock, or albumin of less than 3.5 grams per DL. And acute skin failure mirrors the general health of the patient, meaning that as the other organs start to fail, the skin as an organ also starts to fail. Unlike pressure ulcers, acute skin failure may occur despite the implementation of all appropriate preventive measures. The clinical differences between a pressure ulcer presents as a round, reddish lesion at the bony prominences. Acute skin failure lesions, described as pear-shaped, butterfly-shaped, or horseshoe-shaped, and are sometimes irregular-shaped, red, yellow, or black ulcers, similar in appearance to abrasions that may occur suddenly. Pressure ulcers are markers of coexisting illness and not an independent risk factor for increased mortality. However, acute skin failure can be a risk factor for increased mortality. Documentation considerations for physicians. Though there is no current written criteria for acute skin failure, if they continue to document that all care is provided to try to prevent skin breakdown and it is still there, then they can call it acute skin failure. Using terms of acute skin failure and pressure ulcer interchangeably will result in a query for clarification of the skin condition. Everyone should be on the same page. So the physician, if he writes acute skin failure, the wound care nurse should write acute skin failure, the nurse doing the assessment should write acute skin failure. There should not be any deviation that mentions pressure ulcer in there. Otherwise, a query will have to be documented, have to be written for clarification. Okay, failure to accurately document distinguishing clinical factors for pressure ulcers versus factors for acute skin failure can result in CMS financial reimbursements and legal consequences. So when we may develop a hack or a harm, especially if they document that it's a pressure ulcer that was not present on admission, that becomes a hack. Accurate documentation leads to capturing the true severity of the patient's condition. Here are my references. I have an appendix here, the causes of mortality in patients with acute skin failure. I also have long-term complications of acute skin failure. And here, hypothermia effect. So as the patient starts dying and they start becoming hyperthermic, sometimes hyperthermia occurs. They will have different skin breakdown, different losses. That is it for today. You can contact me through email at dhughes, HUGHES 71720 @yahoo.com, or you may also subscribe to my YouTube video and put in comments, and I will get back to you as soon as possible. Thanks. Bye.